Hi, I wanted to thank the Support Association for inviting me to come and talk about the work of the UK Adult ITP Registry, of which I'm the Chief Investigator. So during the course of this talk, I thought it would be helpful to talk about how the registry is structured, the current team members within the registry, recruitment processes, and then a discussion around the studies that we've been involved in, the collaborations, and a few slides on hopefully what you find is interesting information that we're starting to understand a bit more detail about ITP in the UK. So the registry was actually set up many years ago by Drew Proven, many of you who will know, and is based at the Royal London. So that's a picture of the Royal London Hospital, and we link with Queen Mary University of London for the university element. And I'm currently the Chief Investigator, having taken over when Dr. Proven retired. We have two study managers, study coordinators and data managers, Harimir and Atikamir. We have a study management group and then a steering committee of national clinical experts. And as a group, we therefore make sure that the structures and governance around the registry are appropriate. So we recruit from 90 acute hospital trusts in the United Kingdom, with the predominant being in England, few in Wales, and some in Scotland, with another site opening, which is exciting. And as of the 4th of May, the current number of consented patients with primary ITP is 4,740. So this is our recruitment. You can see from its inception in 2007 how the numbers have increased. In 2018, we closed recruitment for a bit to rewrite some of the data sets so that it was easier to capture and analyse the data, and then had a catch-up year after that. With steady state, and actually we've recruited despite COVID reasonably well, although many sites have not been able to recruit for a short period of time during COVID. Most sites are back open now, and the heat map on the right shows really where the concentration of recruitment of sites is. So certainly there's a concentration in London, and that is partly because we've got quite a few big centres in London, and then patients move in and come in to see us from the peripheral regions, but in a reasonable distribution across the United Kingdom. So as far as the design of the database, the data is entered remotely into a system called REDCap, where we've designed the questions that we want. The information is anonymised, so when you give consent to the clinicians to take part, you're given an identification code, and that is what is used then for any subsequent data entry and sample sending off. It's not your name or anything else. And when the sites log into REDCap, they can select registry, pregnancy registry, depending on the arm, and there will subsequently be secondary ITP registry. And then following on from that, for each patient, there's a traffic light system for all the different sections that we ask about, information about where you're looked after and the clinician, information about kind of lifestyle, basic epidemiological information, sex and ethnicity, and then information around bleeding events, treatments such as splenectomy or the medical treatment, supportive therapy, etc. And once each section is completed, it goes green, and if still areas to complete, it is red. And you can see there then, once somebody's completed all of the relevant sections, it goes green, and then there's an opportunity to follow up information afterwards. So how are we doing in the UK with regards to registries? Well, there was recently across Europe, we looked at the different registries that are available in the different countries. So this is a long list of European, including UK ITP treating teams who are part of the European Research Consortium on ITP, ERC for short. And that's a kind of loose association really of clinicians who are interested in developing ITP research, sort of formally funded body as such. And we were listed within that, so they pulled together all the information of the existing registries, that are, some of which are structured differently across Europe. So this is quite a busy slide and we won't go through all of it, but there are different styles to collecting data within a registry. Some of them are clinical registries and studies like the R1, some of them are population-based studies based on insurance or other schemes. And as far as the clinical studies go, The UK Adult ITP Registry is the largest when we're not looking at kind of whole population data, but it's a large registry, and likewise the pregnancy registry is in evolution really. We are a little bit behind setting up our registry, slower than these others, so our numbers are a little bit lower, but we hope to be able to catch up soon. So this is a table of all the studies and collaborations that we've been taking part in and developing. And I think the registry really comes into its own as we start to look at data, look at patterns, try and identify groups who do or don't particularly respond to treatments, and try and look at studies where a clinical trial might be very difficult for various different reasons. And try and look at the kind of real world practice, because clinical trials are fantastic, but often they're quite narrow, perhaps in the types of patients that can be recruited. Whereas in something like the registry, it's any patient that's given a particular treatment or therapy or how they've responded. And so there are some advantages to that. And this is the list of studies that we've been presenting and are writing up as papers and are ongoing at the moment. So we've looked at different dosing regimens for rituximab, which is a medicine that suppresses the immune system. We've been looking at generally the epidemiology of ITP in the UK, so that's kind of how common it is and what the different groups are. We've looked at splenectomy, which I think is important, and I'm going to show you a couple of slides on that. We've looked at comparing rituximab and mycophenolate. We've looked at treatment changes and what we're using perhaps differently than we were 20 years ago. And hopefully, ultimately, we will extend that into whether patients respond differently to the different therapies. We've done a study on looking at the different treatment usages during COVID and how that's changed. And that I can't show you now because we're presenting at a meeting called the International Society for Thrombosis and Hemostasis in the summer. And then we've got some ongoing collaborations that are both looking at data, but also looking at the biological samples that patients can send in. So we're looking at some genetic changes in a receptor that it mediates the response to rituximab and intravenous immunoglobulin, and comparing that, and Quentin Hill from Leeds is leading on that with me. We've got the Interest UK study, which is looking at L-Tromopag responses, and then quite a bit of work around the COVID vaccination and ITP, which are all still ongoing. So we did an analysis last year just to kind of where are we, and of the 4,116 patients that we looked at the time, we had a median age of diagnosis of 52 years. And you can see that actually the bulk of the patients have been diagnosed with ITP since 2009, but we've got a reasonable number of patients diagnosed kind of 2008 earlier. So that's very helpful when we're looking at long-term follow-up and long-term responses. It's good to know. Although obviously a lot of the newer treatments like L-Tromopag and romoplostim really have only been around in the last kind of 10 to 12 years for meaningful use. And therefore that longer-term follow-up is really helpful for things like splenectomy and some of the older therapies to see what the responses are. We looked at patients who do and don't need therapy, and I think this is quite interesting that about a third of patients don't need any treatment at all. It appears about a third have kind of just steroids, a single course of something, and then don't need much more treatment. And then about a third need steroids and subsequent lines. So second, we've put second here, but subsequent lines of therapy. So not everybody needs treatment up front, and not everybody needs treatment after steroids, but a sizable proportion do. As far as the steroids and intravenous immunoglobulin, actually that pattern hasn't changed. So prednisolone is the blue line, intravenous immunoglobulin is the orange line, and grey and yellow are two other types of steroid. Dexamethasone and methylprednisolone that you may have heard of and may or may not have had. We use a little bit more dexamethasone now, about 12% compared to 10 and 20 years ago. But the vast majority of the steroids are prednisolone. That's fairly static. Now we haven't, obviously this predates COVID-19, significant analysis. So it'll be interesting to see whether that changes things. So we've gone on and looked at the second line therapies to try and understand what we're using and therefore hopefully understand responses. So each column is a different therapy. So we've got mycophenolate, which is a medical therapy, splenectomy, which is a surgical therapy, having the spleen removed, rituximab, romiplostim, eltrombopag, azathioprine, and cyclosporine are the most common ones. And of these, mycophenolate, rituximab, azathioprine, and cyclosporine are medicines that suppress the immune system, and eltrombopag and romiplostim don't. And you can see the first column is blue, and that is kind of overall, and then green is the longest time stretch ago, grey is the middle 10 years, and red is the most recent. And we can see that actually we are using more mycophenolate over time. If we look at the mycophenolate bar, we can see that splenectomies we're doing very few of now, and I think we've known that before and have discussed that in the previous meeting last year. We can see that rituximab has gone up a bit. Romiplostim and eltrombopag definitely. I mean, they weren't really available in, as we said, in the earlier years. And if you combine those together, actually, they're as a class of drug more common than anything else now in the next line of therapy for ITP patients. With azathioprine behind, and I think that's got particular setting for pregnancy, and cyclosporine used a bit, but not that commonly. And one of the studies we wanted to understand is there are different dosing regimens for rituximab. You can have a kind of lower dose, which is given once a week for 4 weeks, but the total dose is smaller. Or you can have a higher dose, which is a more traditional dose for ITP. And off the back of actually some hospital trusts not being able to access funding for the higher dose of rituximab, several years ago, Dr. Progan and Professor Newland looked at whether lower dose was as effective, and on a smaller pilot study felt that it was. And certainly from the registry data that we've published and we're writing up at the moment, I've only shown you platelets here, but the same applies for bleeding events and other response measures. The lower dose and the standard dose, generally speaking, appear effective for primary ITP. Slightly different, I think, for secondary ITP and those of other autoimmune diseases. So I think we have to caveat that and be careful what specific conclusions we make. But generally speaking, these are called box whisker plots, and the line in the middle of the box is the average. The box itself is the kind of distribution, and then you've got kind of outliers of the extreme dots. So you can see that there is no significant difference between any of those, blue being low dose, red being the standard dose, and there is no significant difference between them for each of the different doses, and these are different time points over 12 months. The next bit of interesting information that we have looked at that I felt was helpful to share with you was understanding outcomes after splenectomies in the UK. We don't do so many splenectomies now because I think as a community in the UK, we feel there's probably other alternatives. However, some patients would prefer to have a splenectomy and have the spleen taken out, and if it's successful, never need any more therapies. And certainly internationally, there are some countries that still quite like to do splenectomies on patients and feel that they have a role. I think they do have a role, but I think it's quite a narrow role. So we looked at the time, there were 4,000 patients recruited into the registry. By the time we'd looked at those who had splenectomy, those that were removed because of missing data sets, we had 347 patients to analyse who'd had a splenectomy anywhere between 1951 and September 2009, so quite long follow-up, with total patient year follow-up of 3,652. We looked at the average age of people having a splenectomy, which is about 40 years, and a smallish percentage were over the age of 65, and I will show you why that's important in the next slide. The average follow-up was 7 years, but actually you can see there's quite a wide range when we look back at when the splenectomies were performed. The percentage of patients receiving splenectomy, certainly in the last 10 years bracket, is up to 2018 was low, but actually historically up to a third of patients were receiving a splenectomy for their ITP. And the average time to splenectomy has gone up, and the average number of medicines that are being given before a patient gets to splenectomy have gone up. So I think we are using them, but we are using them in patients that perhaps have failed the more standard medical therapies that we're comfortable with. We've done lots of different analysis, but I think this is probably the most helpful one. This is what's called a Kaplan-Meier curve, and this starts at the beginning where 100% of patients are currently have called a response immediately after the splenectomy, and then every time somebody loses response, it drops down a point on the curve. Now, this curve is comparing men and women, male and female, and there is no difference in the response between men and women. And you can see that over time, so by the time we're getting to 5 years, the response to splenectomy has tailored off. We're also probably slightly favouring those who haven't responded here, but generally speaking, we are seeing quite a significant drop off. So there are some patients who do very well and do very well long term, but there are plenty who actually ultimately have further problems with their ITP down the line. But it can be very successful if somebody's really struggling with their ITP. This one I think is important. So this is comparing patients over the age of 65 and under the age of 65. And patients who are over the age of 65 who have splenectomy generally have worse response rates than those who are under 65. And we know that generally from the literature, and I think that is reflected in the percentage of patients over the age of 65 who have had a splenectomy. And the complications of splenectomy that we found overall is about 12.5% infection rate, which is reasonably high for a procedure, particularly when it lasts longer term. And about 15% of patients have thrombosis. And we know that thrombosis is a recognised complication of splenectomy for whatever reason you have a splenectomy. And in this cohort, 23 were venous, so in the veins, 27 arterial, so that would be strokes, TIAs, heart disease, and 2 patients had both. The vast majority of those who had an infection had one, but there were several patients who had 2, 3, 4 repeated infections. And there were 13 deaths overall in this group, but actually only 1 was attributable to splenectomy. So whilst no direct mortality associated with the splenectomy, obviously there's an increased complication rate with infection thrombosis. So again, they can be very successful for a group of patients. But there are issues to discuss if you're going to consider a splenectomy. So the next study I wanted to just talk through briefly is something that we've presented fairly recently, actually, at the British Society of Haematology meeting. And this is an example of a study where it would be very difficult to do this as a randomized controlled trial because we are moving away from generally immunosuppressing patients with primary ITP, and because in order to fund this kind of study with the medicines involved, it would be quite challenging to do this randomized. And therefore real world evidence where we can take the groups of patients that have had each of those agents and compare them longer term can be very helpful to try and understand the comparative effectiveness of these, particularly when we're talking to you as patients about what your options are and where we think you might go next. So we compared mycophenolate and rituximab. So all patients who had had mycophenolate or rituximab in the registry, and overall we had 844 patients, slight preponderance or slightly increased number in rituximab, 486, 358 in mycophenolate. This is quite a busy slide, and I don't expect you to take it all in, but it was just really to show the p-value here is something we look for, whether there's a significant difference in the thing that we're looking at between the two groups. So was there a significant difference in age or sex or time since the ITP was diagnosed, or the number of prior treatments for ITP, or the number of weeks at risk is the kind of follow-up, because actually that might be something that would affect the results. But actually, as it stands, if this p-value is greater than 0.05, then there is not reported to be any significant difference between the group. There is slightly longer follow-up in the rituximab group after they've been given rituximab, but it didn't reach that kind of 0.05 statistical significance. Again, this table is quite busy, and it's really to just illustrate and show that there was a significant difference in the number of patients on additional therapies when they were receiving either mycophenolate or rituximab. So more patients in the mycophenolate group were on steroids, and more patients in the mycophenolate group were on a TPO-RA at the same time than rituximab. And this is the percentage of patients that we could see reaching the response criteria. And in studies for ITP, the platelet response criteria, and I accept there's lots of different ways of measuring response in ITP that are more sophisticated than the platelet alone. But generally speaking, most ITP trials have a platelet count as the response. A partial response is counted as a platelet count of over 30 and doubling baseline, by which we mean if your platelet count was 10 at the beginning, or 15 at the beginning, you'd have to have them over 30 and doubling that baseline. Yeah, because if your baseline was, for example, 40, and then you went to your platelet count was over 30, you hadn't doubled baseline. You couldn't tell whether that was a response or not. Complete response was platelets over 100, and no response was an absence of both of those. And we can see, so this is 4 weeks, 12 weeks, so 3 months, 6 months, and 12 months. And the blue is no response. So over time, it takes quite a while for rituximab to work. It doesn't happen immediately. We know it can take several weeks, and actually you can, even though you get an initial response, you can see further response almost up to 3 months, and that's well recognized in other autoimmune diseases as well. So we see about a third of don't have response at 4 weeks, but actually by 12 months it's about 20, just between 60 and 20%. And we've got a gradual increase in complete response to about 40% and partial response 43%. So we're seeing good response rates in rituximab, and the same in mycophenolate, but interestingly, it can take a little bit longer from a mycophenolate point of view for things to work. So overall, just coming back to that slide, we have got some information looking at the duration of response, and generally speaking, it looks like the duration response is perhaps slightly longer for rituximab than mycophenolate, but mycophenolate patients were also on other medications, and so we think that that might be coming into play when those other medications come off a little bit and we've lost the combination. It may well be that you lose the response bit to mycophenolate, and we're just looking into that a bit more detail. But I think this is very reassuring that actually, if you are thinking about the immunosuppressive medicines and that's what's needed for your ITP, you could think about rituximab or mycophenolate, and some patients prefer the injection, which is rituximab, some people prefer the tablet, which is mycophenolate, and you can be reassured that generally speaking, both are broadly as effective as each other. So just going to spend the last bit of this talk talking about the Adult Pregnancy Registry, which is a late-ish addition to the registry and is co-led by Sue Robinson at Guy's and St Thomas's. This data cutoff analysis was April 2021, but we recruit from several sites, many sites across the country, again with a bit of a heat map in London, but dotted around, and actually Dr. Baggett in Scotland doing really well with recruitment. I think pregnancy ITP is a rare event. ITP is a rare disease, and then it's a small percentage of people who have ITP who are in a childbearing age bracket. And so it's not a common event. And there have been snapshots through other methods. There is a UK obstetric surveillance survey that was done a few years ago about ITP. But the advantage of this particular study of ITP is that we can link it. If you had ITP before, we can link it together and start to understand a little bit more about how ITP behaves in pregnancy in comparison to how it may have behaved before, as well as asking a little bit more information and more detailed information that we can do, because this isn't a snap survey, this is a research study. And we've got biological samples and genetic samples to be able to line this up as well. So at this snapshot in April 2021, we had 40 women recruited at that time, of whom 29 had delivered, and we had data for 39 patients, although not all of those had delivered. And the average age was 33 years, which we would expect for women having children. The average lowest platelet count during pregnancy was 70. But that ranged from 0 to 317. So there were some ladies with quite challenging ITP. And the average platelet count at delivery was 111, ranging from 30 to 317. We generally recommend a target of around 50, and ideally a platelet count of around 50 for women delivering, higher if you wanted epidural, because of the risk around the spinal cord with an epidural. So there are some ladies who are delivering at lower platelet counts than that because the ITP is more refractory. And the average platelet count at 3 months after delivery was 167. So a lot of that had got better. So we can see that, generally we accept a platelet count actually of down to 20 during pregnancy unless there's problems with bleeding. So we do allow platelets to be a bit lower, and we can see that reflected in the average lowest platelet count during pregnancy. And bit by bit, the platelet count comes up, and we intervene with therapies to support that for delivery. And then after delivery, not everybody's ITP gets better, but a substantial proportion do, and the average platelet count comes up. So this is the bleed events during pregnancy, with number of participants having an event at the bottom, and patients may have had more than one bleed each. The main one is nosebleeds, and that's interesting because I think any pregnant woman can actually develop nosebleeds, but ITP may well be making that worse. Others being gynecological and gum bleeding and easy bruising. So generally what we would expect. Those patients needing treatment before pregnancy, most would have some low-dose steroids, some would have IVIG, some had rituximab, and some had eltrombopag and romiplostim. And actually the rituximab, romiplostim, eltrombopag are not licensed in pregnancy, and I think it doesn't surprise us that a lot of patients had prednisolone before pregnancy and any of these agents, and but generally we don't have patients on eltrombopag or romiplostim or mycophenolate going into pregnancy, so all of those would need to be stopped. Azathioprine is safe for pregnancy, and rituximab needs to be discussed. During pregnancy, again, prednisolone was the most common, followed by IVIG, and then romiplostim and azathioprine for small numbers of participants. We've just said in the last slide that romiplostim isn't licensed in pregnancy, and it isn't. However, towards the end of pregnancy, if the platelet count isn't coming up, it has been used and reported to not cause any problems in the mum or the baby. So if it is needed, it is possible, but it does require quite close discussion and informed consent. And then for treatments after delivery, 3 of the 39 patients required treatment after delivery, romiplostim, methylprednisolone or prednisolone, so not very many. And again, that just reflects us needing to support the platelet count to safely get the baby out. Once the baby's out, things seem to get a lot better. We can cut back from treatment, and not as many ladies need treatment. This is where I think the information is interesting, and I think will be a kind of further sub-study when we've got enough patients to analyse, that 17 of 29 patients were delivered by caesarean section, which is a higher rate than the average caesarean section rate. We don't have any information yet on why, whether that was because the platelet count was lower, whether patients needed a fixed date of delivery to be able to plan other medicine use like intravenous immunoglobulin. And when we've got more patients recruited, we can start to understand this a little bit more, because that is higher than average. And afterwards, there were only 4 who had bleeding, 2 postpartum hemorrhage, 1 wound hematoma, and 1 bleeding in the perineum around the delivery. So it will be interesting, I think, to investigate that higher rates of caesarean section. So where are we going next in the registry? Just as my kind of last slide, we've got some active projects we're moving on next, particularly around vaccine ITP, and to be able to inform you of those risks, and that links with the Public Health England snapshot survey of vaccine ITP as well. We're moving to look at secondary ITP, so we've got ethical approval to add in secondary ITP. This is a less defined syndrome sometimes, and there's lots of other things to think about, not just the ITP information, but the other things that are associated with the ITP, like trying to understand if it's with lupus or lymphomas or other conditions, what we want to collect about those, and they're kind of more complicated information sets really that we need to make sure we've got right. But we are making inroads into doing that, and I think that will be very helpful as well, because a lot of the clinical trials for ITP are actually only in primary ITP, not secondary ITP. And so those with secondary ITP are perhaps a slightly underrepresented group, and it would be nice to have a bit more information about that to help guide decision making and optimising care. And really, I put collaborations and ideas here, please. This is a slide I often use for clinicians as well. And we work closely with the Support Association, but we are open to suggestions, from via the patient support group for studies that might also be useful if felt to be appropriate. So I'll just quickly finish by saying a big thanks. A big thanks to you all for listening. Thank you to the ITP Support Association, who are very helpful when we have questions, and we want a kind of patient representative to perhaps answer some questions that we have, and also for funding. for supporting some of our data management. We also have had some educational funding from Grifols and Novartis for some of our projects. Goes without saying, I want to thank the team that works at London. This is not an individual's work, it is a team project. And also to the PIs and the doctors and nurses and data managers that look after you and help enter the data as well, because without that, that wouldn't be possible. So I will stop here. Thank you very much, and I hope you're enjoying the conference and enjoy the rest of the weekend. Thank you.